It is important to minimize the pressure applied to the submandibular soft tissues, as this may further obstruct the airway by pushing the tongue against the palate. Maintaining an adequate seal while extending the head, thrusting the jaw forward, and squeezing the bag with the other hand may require considerable manual strength and coordination. Extreme caution is advised in patients with cervical spine injuries, in which flexion or extension of the neck is contraindicated. In this situation, the jaw thrust maneuver alone, without head extension, is recommended. It may be difficult or impossible to maintain an adequate seal using only one hand. This challenge can occur in obese or edentulous patients, or in those with abundant facial hair. Additionally, large patients may present a challenge for individuals with small hands or with insufficient manual strength or dexterity. In these situations, the mask can be held with two hands, with each hand positioned as described in the one-hand technique. A second person compresses the bag valve device. Regardless of the technique used to ventilate the patient with a face mask, adequate ventilation can be assessed by inspecting and auscultating the chest and abdomen. The chest rising and falling and breath sounds synchronous with the delivered tidal volume suggest adequate ventilation. Gurgling epigastric sounds and tympanic abdominal distension indicate gastric insufflation and poor ventilation. Other monitoring tools such as pulse oximeter and a carbon dioxide detector can be very valuable. Occasionally, it is difficult or impossible to provide ventilation unless an oral or nasal airway is inserted. These devices are most helpful when the cough and gag reflexes are absent. Insertion in patients with intact reflexes may precipitate coughing, vomiting, and laryngospasm. When used, the appropriate size device must be selected in order to avoid worsening of the airway obstruction. Too small an oral airway may push the tongue against the oropharynx. Too large an oral airway may push against the epiglottis and trigger laryngospasm. The correct size of an oral airway may be estimated by holding the airway next to the patient's mouth. The tip should reach the angle of the mandible and no further. An oropharyngeal airway can be inserted by depressing the tongue with a tongue blade and advancing the airway towards the base of the tongue. Alternatively, the airway can be inserted upside down and then rotated 180 degrees as it is being advanced posteriorly. In general, nasopharyngeal airways are better tolerated than oral airways when airway reflexes are present. They are particularly useful when the mouth cannot be opened. The simplest method of estimating their appropriate length is by correlating it with the external anatomy of the face and neck and taking into consideration the patient's height. Nasopharyngeal airway should be thoroughly lubricated and advanced perpendicular to the face and parallel to the floor of the nose, not towards the roof of the nose. They must be used with extreme caution in patients with facial injuries, basilar skull fractures, and coagulopathy, weighing the risk of further injury and bleeding against the need for oxygenation. Raising the head of a bed may facilitate the delivery of adequate tidal volumes, but may be contraindicated because of hemodynamic instability, or may be impossible, for example, if the patient is on the floor. When the patient is breathing spontaneously, one must synchronize the delivered tidal volume with the patient's inspiration. Regardless of the presence of spontaneous respiratory effort, when excessive pressure is delivered to the airway, gastric insufflation may occur. This may lead to a vicious cycle of increased intra-abdominal pressure, which requires higher peak inspiratory pressure and can result in further gastric insufflation. This not only reduces effective ventilation, but predisposes patients to vomiting or regurgitation. Complications other than the inability to ventilate can occur, including corneal abrasions and blindness in the presence of a severe eye injury. Soft tissue injuries, particularly to the bridge of the nose and lips, may result when excessive pressure is applied. Complications such as trigeminal and facial nerve compression have been reported due to continuous, prolonged pressure on the facial structures. Discontinuation of face mask ventilation depends on clinical circumstances. Patients may require a more definitive airway management, such as endotracheal intubation. On other occasions, all that is needed for patients to recover completely is effective face mask ventilation with oxygen. Every physician should be familiar with this potentially life-saving technique.